Good morning, everybody. I would like to thank the National Hemophilia Foundation for giving me this wonderful opportunity to talk to you all about Factor Five and the blood disorders which are related to Factor Five. These include Factor Five deficiency, combined Factor Five innate deficiency, and Factor Five short, which is in fact a mutated protein resulting in two bleeding disorders that we know of today. These include East Texas bleeding disorder and Factor V Amsterdam. I have no relevant financial disclosures. In today's discussion, I will be talking to you about each of these bleeding disorders, initially describing the role of these coagulation proteins in clotting, then moving over to the diagnosis of these rare conditions by talking about how the mode of inheritance and family history helps us, moving on to the clinical features, and finally, the lab diagnosis of these rare conditions. I'll talk about the treatment that is available today and what do we need to do in the future to further the care of these patients with rare bleeding conditions. So let's start with Factor V and its role in blood clotting. Now, Factor V deficiency has several names. It's also called Overen's disease, parahemophilia, labile factor deficiency, and proaxillerin deficiency. For the very first time, Factor V deficiency was reported by a Norwegian physician by the name of Dr. Paul Overen during World War II. He was taking care of a 29-year-old young female by the name of Mary, who had started with her bleeding symptoms at the age of 3. She had nosebleeds, easy bruising, and then later on had heavy menstrual cycles. Now, it is important to know that Factor V is primarily made in the liver, but about 20% of Factor V is present in the platelets. Now, going over to the role of Factor V in blood clotting. As you can see here, in this particular figure, Factor V is a common connection between two parts of the coagulation cascade. It has a very important role to play in generating thrombin, which helps in the formation of a stable clot. Hence, deficiency of Factor V results in bleeding symptoms. Moving on to the diagnosis. It is a very rare bleeding disorder with a prevalence of about 1 in a million. There are 56 mutations that we know of. Majority of the people who have severe Factor V deficiency, that is very low levels of Factor V, have null mutations. A null mutation is one in which no protein is being synthesized. It is an autosomal recessive bleeding disorder where males and females are equally affected. So what is an autosomal recessive disorder? As you can see in this figure on the right, both the parents carry the mutant gene. As a result of this, the child carries a copy of the mutant gene, one from the father, one from the mother. So 2 copies of the mutant gene are present. In such conditions, parents usually are not affected with the bleeding symptoms, but are just carriers. And in each pregnancy, there is a 25% chance that the child will not have the disease and will not be a carrier. There will be a 50% chance that the child could be a carrier and a 25% chance that the child could have the disease. These blood disorders are very common in areas of the world where consanguinity or marriage among cousins is very commonly seen. Genetic counseling is important to know the risk for future generations. And if prenatal diagnosis is sought by the parents, then this should be done only at centers where expert facilities for fetal diagnosis are present. Moving on to the clinical features of Factor V deficiency. According to the North American Registry for Rare Bleeding Disorders, Factor V deficiency is classified as severe if the levels are less than 20% and mild if the levels are more than 20%. It is important to remember that bleeding might not correlate with levels. That means that you could have very low levels and not have many bleeding symptoms. We also have some data from the Iranian registry, which classifies patients slightly differently. According to that registry, severe patients are those who have levels less than 1%, mild patients have levels between 6 to 10%, and moderate patients are in between these levels between 2 to 5%. As you can see from this graph here, 30% of the patients are asymptomatic, which means they do not have any bleeding symptoms. 30% of these patients have minor bleeding, mainly in the skin and the mucous membranes, which includes easy bruising, nosebleeds, and some women can have heavy menstrual bleeding. 20% have bleeding mainly after injury, surgery, or if they are on blood thinners. Very few, that is only about 14%, have bleeding in the major organs which can be life-threatening, like in the brain, in the gut, or the joints and muscles. In the Iranian cohort, 50% of the women had heavy menstrual cycles, 43% had bleeding after delivery. In women, if the levels are between 1 to 10%, then they could suffer from recurrent miscarriages, premature births, and fetal losses. It is important to remember that most of the severe patients present with bleeding symptoms, the patients who have mild, low levels, will usually present at the time of family screening, or if they are worked up for a pre-op screening process with labs. Otherwise, they might go undiagnosed for a long time in their life. So how do you diagnose in terms of a laboratory workup if you have factor V deficiency? As we had seen in the initial figure, factor V has a very important role to play as a common pathway factor. That means if you have factor V deficiency, both the clotting screens, which is the prothrombin, and the activated partial thromboplastin time, or the APTT, would be prolonged. If you have factor V deficiency, do check a factor VIII level, because combined factor V and VIII deficiency can exist. Acquired factor V deficiency is a rare condition, which basically means that you could have low factor V levels because of certain medical conditions, which are rheumatological conditions or malignancies, or rarely if bovine thrombin was used during a surgical procedure. This is a medication which is used to control bleeding during certain surgeries. As a result of these conditions or use of bovine thrombin, a person can develop anti-factor V antibodies, resulting in abnormal PT, PTTs, and a low factor V. However, as soon as these conditions are treated or the bovine thrombin is removed from the system, the patient's factor V levels will normalize. So moving on to the treatment of factor V deficiency, we do not have a specific product to replace factor V like other bleeding disorders, for instance, factor VIII deficiency or factor IX deficiency, also known as hemophilia. So in factor V deficiency, our main replacement product is fresh frozen plasma, or FFP. If there is minor bleeding, as is shown here in this particular column, you could basically get away by using antifibrinolytic agents. These include aminocaproic acid and tranexamic acid, and they help to stabilize a clot and prevent bleeding. If there's heavy menstrual bleeding, as is seen in females, hormonal therapy is the best treatment. However, in certain conditions, if the bleeding is very severe and not controlled with hormonal therapy, one might resort to surgical measures like endometrial ablation or hysterectomy. If there is major bleeding involving the brain or the gut or the joints or muscles, one has to keep the factor V levels at more than 20% of the normal to prevent bleeding, because usually levels of 20 to 25% of factor V prevents most bleeding. In order to do that, FFP has to be given quite frequently. However, some individuals cannot tolerate the volume load associated with FFP, and in such cases, one has to resort to giving platelets because they also have factor V. In a rare instance where platelet transfusions and fresh frozen plasma is not bringing the desired clinical response or achieving the desired factor V levels, one needs to think about factor V inhibitors. In such conditions, recombinant factor VIIa needs to be used. In patients where surgeries are planned, one needs to keep the factor V levels more than 25% of the normal range. Very rarely, some patients would need prophylaxis, which is treatment given to prevent bleeding on a regular basis. This is usually based on the bleeding symptom severity rather than the baseline factor V level, because as I had mentioned earlier, factor V levels do not always correlate with bleeding symptoms. So this particular slide is basically summarizing all the treatment modalities we have available for factor V, starting with fresh frozen plasma, where the dose has to be decided by the provider, and the bleeding symptoms, whether it is a surgical procedure or not. Pregnancy is unique because in this state, you can actually prevent pregnancy losses by just keeping levels above 15%. According to some Iranian data that we have, fresh frozen plasma started in patients at around 33 weeks and given 3 to 4 times in a week would help maintain the pregnancy and would also prevent any postpartum bleeding, that is bleeding after delivery. Platelets, antifibrinolytic agents, and recombinant factor VIIa, specifically for those patients who have inhibitors. So what do we have in store in the future? So as I've mentioned, factor V deficiency is unique in the fact that we do not have a replacement product available. Development of factor V specific replacement products is extremely important and are being developed by Kedrion. Gene replacement therapy may be in the future, but at present, we do not have anything to offer in terms of gene replacement. It is also important for patients and providers to know that there are several resources which are available for these rare bleeding disorders, including the Rare Coagulation Disorder website. There is a global treatment center directory maintained by the World Federation of Hemophilia, and there is the Orphanet website where patient organizations can be found. There are a lot of researchers who are interested in factor V deficiency, and this list can be found at the Rare Coagulation Disorder website. So let's move on to the next factor V deficiency, which is combined factor V innate. Let's talk about the role of factor VIII in the clotting cascade. So as I'd mentioned, factor V has an important role in generating thrombin. Similarly, factor VIII also combines along with factor IX, and both of these factors in the activated form help to activate factor X, which forms an important complex with factor V called the prothrombinase complex, which again finally helps in the generation of thrombin. Hence, deficiency of factor VIII along with factor V results in causing a blood disorder. This was first reported as a combined deficiency by a German physician, Uri, in 1954. The levels of both factor V innate are low, between 5 and 20% in combined factor V innate deficiency. Moving on to the diagnosis, similar to factor V, it is a very rare bleeding disorder with a prevalence of 1 in a million. Now, this particular deficiency of combined factor V innate is not due to 2 separate genetic defects in factor V and factor VIII, but a single gene defect. Most of the mutations, about 70%, are found in a specific gene called the LMAN1, and 15% are in the MCFD2 gene. Again, similar to factor 5, it is autosomal recessive in inheritance, which means that the child inherits 2 copies of the mutated gene, one from each parent. Genetic counseling is extremely important, and males are equally affected as females. The clinical features of combined factor 5-8 deficiency are similar to any other bleeding disorder, with skin bruising, nosebleeds, bleeding from the mouth being very common, which is called mucocutaneous bleeding. Heavy menstrual bleeding can be seen in more than 50% of the affected women. There is not much data available about delivery and bleeding after delivery in such women. Bleeding after circumcision can happen in male babies, but it is rare to have major organ serious bleeding involving the brain and the gut. Again, depending on the levels, this bleeding disorder is classified into 3 different categories. It is severe if the levels of factor 5 and 8 are less than 20%, moderate if it is between 20 to 40%, and mild if the levels are more than 40%. As the levels of these factors decrease, the tendency to have spontaneous bleeding increases. How do you diagnose combined factor 5 and 8 deficiency? By doing the basic clotting tests, both PT and APTT. And in this condition, because the factor 8 is also in low levels along with the factor 5, the APTT is the one which is extremely abnormal. Remember, whenever there's factor 5 deficiency, always check factor 8 because of the combined deficiency. Factor 8 deficiency or hemophilia can be distinguished from combined factor 5 and 8 deficiency by the fact that factor 8 deficiency is X-linked, which means males develop the disease and females are carriers. And in factor 8 deficiency, there will be a normal prothrombin or PT time. However, in combined deficiency of factor 5 and 8, PT and PTT both are abnormal. Of course, factor 5 deficiency can be confused with combined deficiency because both of them are autosomal recessive. Both of the conditions have prolonged PT and APTT assays. It is very rare to have factor 5 deficiency associated with mild hemophilia A, and that can be discerned only by doing a genetic analysis. So moving on to the treatment of combined factor 5 and 8 deficiency, the main treatment products include fresh frozen plasma, which helps to replace factor 5 since we do not have a specific replacement product. And then for factor 8, we use factor 8 concentrate or desmopressin known as DDAVP. For minor bleeding, as this table shows, if you achieve a goal level of factor 8 at 30% and factor 5 of 25%, then you can stop the bleeding. If it is major bleeding, which is life-threatening, again involving the brain, the joints, the muscles, or the gut, you would need to bring up factor 8 to 50% and factor 5 to more than 25%. For surgeries, you can achieve these goals, but you might have to replace the factor 5 and factor 8 every 12 hours because factor does get consumed during surgical procedures. Pregnancy is a unique situation because factor 8 increases during pregnancy due to the effect of estrogen. Factor 5, however, remains the same. It is important to measure these levels during the 3rd trimester, and during labor, one should aim to keep the levels of factor 5 at more than 15% and of factor 8 at more than 50%. If you can keep these levels, the pregnancy will go smoothly. At the time of delivery, epidurals can be given. And in order to replace the factor 5, the fresh frozen plasma should be given during labor and even after delivery for at least 3 days to prevent the bleeding after delivery. Antifibrinolytic agents are important, along with FFP and factor 8 concentrate. And in combined factor 5-8 deficiency, it is very rare to use prophylaxis because bleeding is usually mild to moderate or it is after injury or trauma. So what do we have in the future for combined factor 5 and 8 deficiency? Similar to Factor V deficiency, we do not have any clinical trials at this time. We definitely need to develop a Factor V concentrate, and we very well know that the products of Factor VIII deficiency have really improved substantially in the last few years. There is a lot of data available from registries and databases, and we should make an effort as providers to keep up with this data. There is information available at different websites, which include the France COAG Network, ISTH websites, the National Center for Biotechnology Information, and the Prospective Rare Bleeding Disorder Database. Each of these websites has important information for patients as well as for providers, which can be accessed at any time. So let's move on to Factor V short. So as I'd mentioned, this is actually a mutated Factor V protein. And as a result of this, it results in two bleeding disorders, which is East Texas bleeding disorder and Factor V Amsterdam. This is a little more complicated as compared to Factor V and Factor V innate. There is a protein called the tissue factor pathway inhibitor, or the TFPI. This particular inhibitor, as the name suggests, is responsible for inhibiting a complex called tissue factor 7A pathway. And this is important because this tissue factor 7A complex is responsible for generating thrombin. So if there is high levels of TFPI, then the tissue factor 7A complex will not work. And as a result of this, thrombin will not be generated and the patient will have a bleeding tendency. In patients with short Factor V, there is a high level of TFPI. TFPI has a very high affinity to bind to the mutated Factor V, resulting in high levels of this particular protein. Hence, for diagnosis, a high level of TFPI is key. The two bleeding disorders were recently described, East Texas in 2001 and Factor V Amsterdam in 2015. How do we diagnose these bleeding disorders? Again, very rare. The prevalence is not known because there are only case reports. It is autosomal dominant, which is different from Factor V deficiency and combined Factor V innate deficiency. So in autosomal dominant disorders, as you can see in the figure on the right, about 50% of the children in each pregnancy have a risk of carrying the disease. They have one copy of the mutated gene that they have inherited from one of the parents in this particular condition, or rather figure, it is the father who has the condition and has a copy of the mutated gene. 50% of the pregnancies would be such that the children will not have the condition. Males and females are equally affected, and as it is true for any inherited condition, genetic counseling is important for risk assessment. This is a busy table, and I have put it out here because the description of East Texas bleeding disorder comes from cases which were published first in 2001 from certain individuals who live in East Texas and were found to have this bleeding disorder. As you can see, just like any other bleeding disorder, males and females are equally affected, as happens in Factor V deficiency and combined Factor V innate deficiency. And there can be easy bruising, nosebleeds, gingival oozing, that is gum bleeding. Females can have heavy menstrual bleeding. There can be ruptured ovarian cysts. There could be blood in the ovarian cysts. It's called hemorrhagic ovarian cysts. There could be bleeding after delivery, though not in all cases. You could have a pregnancy which goes well without any bleeding, and there are others who have bleeding. So there is a variable bleeding phenotype seen. These patients were basically treated with packed red blood cells for anemia, as well as fresh frozen plasma. These patients have also been treated with fiber, which is an anti-inhibitor coagulant complex consisting of different factors. Some people are asymptomatic and yet they have the bleeding disorder. Interestingly, East Texas bleeding disorder is no longer confined to East Texas. We have recently identified a family in Indiana at our center. Interestingly, this patient did not have a diagnosis for more than 10 years, and he had severe bleeding symptoms, including bleeding after surgery. He had a scalp surgery due to a scar revision. This resulted in excessive bleeding in the different layers of scalp, which is called the subgaleal hemorrhage. And he was given different products because initially he was thought to have von Willebrand disease because of borderline low levels. He received desmopressin and a specific product for von Willebrand disease called Humate P. And finally, he responded only to recombinant factor 7A at a high dose along with antifibrinolytic agents. Interestingly, this child also had a delayed exfoliation of the umbilical cord and has delayed wound healing. Extended family members have been tested, and 4 other family members were diagnosed with East Texas bleeding disorder, and some of them had normal coagulation tests, the PT and the PTT. Factor 5 Amsterdam is again a condition because of factor 5 shot, and it has been found among the Dutch. 3 generations of a Dutch family have been affected. And again, similar bleeding symptoms like East Texas bleeding disorder, although one child did have prolonged bleeding from the umbilical stump. These individuals were treated with another concentrate called prothrombin complex concentrate, which has certain blood clotting factors, and tranexamic acid, which is an antifibrinolytic agent. But similar to the East Texas bleeding disorder, they had abnormal blood coagulation tests, both the PT and the PTT. So how do we diagnose East Texas bleeding disorder and factor 5 Amsterdam? By doing the clotting assays again. But it is important to remember that some individuals might have a normal clotting screen and might not have many bleeding symptoms. In these individuals, it is important to do TFPI alpha levels, which is currently a research-based test. For the cohort in Indiana, we were able to get TFPI alpha levels with the help of Dr. Alan Mast at University of Wisconsin, who's running this test. Genetic analysis to find the specific genotype defect is important to diagnose East Texas and factor 5 Amsterdam. So what do we do for treatment? As I've mentioned in the table, various treatments are available and are being utilized because we do not have anything specific. This includes recombinant factor 7A, fiber, prothrombin complex concentrate, antifibrinolytic agents, which can be used either orally or intravenously. And as needed, packed red blood cells and fresh frozen plasma can be used. So really, it is very rare to use long-term prophylaxis with any of these products for East Texas bleeding disorder or for factor 5 Amsterdam, as far as it has been reported. There is a high variability in the bleeding features, and most of the patients present with symptoms associated with trauma or surgery. So in the future, for factor 5 shot, we definitely want the TFPI alpha levels to be available commercially and not just a research-based test, so that it can be available for all those individuals who do not have a defined bleeding disorder. Concizumab is a humanized monoclonal antibody which is against TFPI and helps to lower its levels. It has been used as a treatment option for hemophilia, still in development though. It could be theoretically used for treatment of factor 5 disorders because it would bring down the levels of TFPI alpha. So this brings me to the end of the presentation. I just wanted to summarize. So for factor 5 deficiency and combined factor 5 and 8 deficiency, both of them are autosomal recessive, mild, moderate to severe bleeding phenotype. For factor 5 deficiency, bleeding might not correlate with the levels, And treatment for Factor V deficiency is fresh frozen plasma and antifibrinolytic agents. For combined Factor V innate deficiency, you would need to add a Factor VIII concentrate or desmopressin and antifibrinolytic agents. For Factor V shot, it is autosomal dominant in inheritance. Bleeding can be mild to severe. And as I had said, some individuals might be asymptomatic. What we have available as of now is recombinant Factor VIIa, fiber, and antifibrinolytic agents. In summary, Factor V linked disorders are rare bleeding conditions which can manifest with mild, moderate to severe bleeding symptoms. For a diagnosis, you need to have a complete family history, pedigree charting, lab diagnosis, and genetic counseling is extremely important for the education of the family to know future risk assessment. Treatment products need to be developed specifically for Factor V, and future research is needed to further the care of these individuals with rare bleeding disorders. Thank you so much for your time and attention.